Hyperkalemia is a condition characterized by plasma potassium concentration more than 5.5 milliequivalents per liter. Coming to etiophysiology of this condition, etiology, how can the potassium level inside the blood can increase? It can increase because of increased intake of potassium. It can increase because of increased shift of potassium from the cell to the extravascular compartment, that is blood, or due to reduced excretion of potassium from the body, there can be increased potassium levels. The increased intake can be due to intake of potassium containing salt supplements, or due to intake of potassium supplements, or increased shift from intracellular compartment where the potassium concentration is more. Inside the cell, we know the potassium concentration is more compared to extracellular compartment. So that shift from cell to the blood can cause increased potassium levels. It can be due to the breakdown of cells leading on to increased potassium level in blood, or due to potassium shift secondary to other conditions. Now, the breakdown of cells is seen in hemolysis, rhabdomyolysis, crush injury, and tumor lysis syndrome, which increase potassium levels. The potassium shift from cell into the blood occurs in case of metabolic acidosis. In metabolic acidosis, to buffer the increased H+, there will be influx of H+ from blood into the cell and efflux of K+ from cell into the blood, causing hyperkalemia. Then, in case of insulin deficiency, we see hyperkalemia. Why? Because insulin normally is responsible for the increased expression and activity of sodium potassium ATPase pump. We know that sodium potassium ATPase pump will pump out 3 sodium ions from the cell, and there will be influx of 2 potassium ion into the cell. It is an active process. So there will be increased level of potassium maintained inside the cell due to this pump, that is sodium potassium ATPase. Then the potassium from the inside the cell can leak out through leaky channels into the extracellular compartment. So due to decreased activity of sodium potassium ATPase following insulin deficiency, there can be hyperkalemia. Why? Because there is reduced influx into the cell, so thereby causing hyperkalemia. Decreased excretion. The renal excretion can be decreased in case of acute renal failure, chronic renal failure, or due to impaired action of aldosterone on principal cells located in distal columnar tubule and collecting duct. It can happen. The reduced amount of aldosterone and its action can occur due to Addison's disease, where there is reduced secretion of adrenal cortical hormones. There will be reduced mineralocorticoids levels in the blood, causing reduced aldosterone. The intake of drugs like ACE-ARB inhibitors can inhibit the actions of, can reduce the level of aldosterone, thereby causing reduced excretion of potassium and hyperkalemia. And drugs like ketoconazole also reduces the action of aldosterone on its receptor. So how this aldosterone hormone is responsible for potassium excretion is, we know that the aldosterone causes the expression of ENaC channels, the epithelial sodium channels, and here there will be reabsorption of sodium in exchange to excretion of potassium and hydrogen. So decreased action of aldosterone will cause decreased excretion of potassium, causing hyperkalemia. This is about the etiology of this condition, hyperkalemia. Next, going on to pathophysiology, why we see particular clinical manifestation in this hyperkalemia. Normally, the resting membrane potential of the cell is between minus 17 microvolts to minus 19 millivolts. Sorry, not microvolts, millivolts. Minus 70 millivolts to minus 90 millivolts. So this resting membrane potential is maintained by sodium potassium ATPase pump and leaky channels. Whenever there is increased level of potassium inside the blood, it reduces the potassium gradient between the cell and the blood. So due to reduced gradient, there will be reduced amount of potassium going out of the cell into the blood through the leaky channels. Because there is already hyperkalemia inside the blood, the increased potassium level, this causes a reduced leaking of potassium from the cells into the blood. So this causes the resting membrane potential to be less negative, because there is more and more potassium being accumulated inside the cell, secondary to reduced concentration gradient. Due to this less negative resting membrane potential, now what happens is, initially there will be increased excitability of the cells due to increased positive ions inside the cell. So gradually, as the potassium level increases, the resting membrane potential leads up to the level of minus 60 millivolts. At this stage, there will be sustained depolarization. We all know that the sustained depolarization will cause inactivation of voltage gated sodium channels. The inactivation of voltage gated sodium channels will cause muscle paralysis and weakness. And due to impaired potassium channel function, secondary to hyperkalemia, there will be disturbance in repolarization. We all know that the potassium is responsible for a repolarization of ventricles. The wave depicting ventricular repolarization is T waves. So in early hyperkalemia, we can see tall, slender peaked T waves. Here you can see tall, slender peaked T waves. This about the idiopathic physiology of this condition. Coming to clinical manifestation of hyperkalemia, usually between 5.5 to 7 milliequivalent per liter, we don't see clinical manifestation. The patient will be asymptomatic. So hyperkalemia has been called as silent killer, because initially we don't have any symptoms. Suddenly the patient can develop the dreaded complications like cardiac arrest, ventricular fibrillation, leading on to death in some cases. So it's called as silent killer. If the value of potassium is more than 7 milliequivalent per liter, the patient can develop muscle weakness. We already saw it's due to the reduced level of the activation of the voltage gated sodium channels. The inactivation of voltage gated sodium channels will cause muscle weakness. The patient can have flaccid paralysis. We see ascending type of paralysis in this hyperkalemia, where the lower limb muscles are involved first, followed by trunk muscles, upper extremity, and head and neck muscles. Due to the inactivation of voltage gated sodium channels, the patient can have paralytic ileus, so the patient can present with abdominal distension. The cardiac manifestation, due to reduced excitability of the cardiac tissue, we can have hypotension, bradycardia, and as terminal events, we can have ventricular fibrillation and cardiac arrest, and may lead to death of the patient. Now, this is about the clinical manifestation. Coming to investigation, the ECG findings. Initially, we'll have tall peaked T waves due to disturbance in repolarization of ventricle, and also short QT interval. We saw this tall peaked T waves and shortened QT interval, followed by as the potassium level increases, it causes disturbance in intracardiac conduction. Due to this, there won't be the ventricular depolarization, causing loss of P wave and widened QRS complex. Here you can see the loss of P wave and widened QRS complex. And after this, if the potassium level continues to continues to increase, and it becomes more than 8 milliequivalent per liter, then we'll have sine wave pattern of in ECG, where the QRS complex will gradually widen, and it merges with T wave to form sine wave pattern. At this stage, the cardiac tissue will not be excitable, and it causes the production of ectopic beats and ectopic stimulus impulses, causing ventricular fibrillation, and the patient can have cardiac arrest as a terminal event. The treatment of this disease, to prevent cardiac arrhythmia like ventricular fibrillation, we give calcium gluconate, 10 ml of calcium gluconate in 10% solution, IV given over 2 to 3 minutes. Then to increase the shift of potassium from the blood to the cells, we can use insulin and dextrose infusion, which causes shift of potassium into the cells. We can use 50 ml of 50% dextrose with 10 units of insulin every 6 to 8 hours. We can use sodium bicarbonate IV, where 1 to 2 ampules of sodium bicarbonate we can give IV. It causes increase in pH inside the blood, which causes the movement of potassium into the cell. We saw metabolic acidosis causes hyperkalemia by shifting of potassium out of the cell here. So we are causing Metabolic alkalysis is like condition by giving sodium bicarbonate, which shifts the potassium into the cell. This is sodium bicarbonate and insulin and estrogen fusion, and also we can give beta 2 agonists like salbutamol, which causes shift of potassium into the cell. Now we can increase potassium excretion by giving sodium polystyrene sulfonate, which is a resin. It binds to the potassium and causes the excretion of potassium in the stools. We can also give diuretics like furosemide and thiazides, which causes increased excretion of potassium. In the patient who have severe hyperkalemia, that's more than 6.5 milliequivalent per liter with renal failure, we can try hemodialysis, which causes a rapid correction in potassium levels. This is about the treatment of hyperkalemia. To summarize, hyperkalemia is a condition where we see plasma potassium levels more than 5.5 milliequivalent per liter. The etiology of this condition, due to increased intake like potassium containing salt substitutes and potassium supplements, the patient can have hyperkalemia due to increased shift from the cell into the blood in case of breakdown of cells seen in hemolysis, rhabdomyolysis, crushing tumor lysis syndrome, and in case of metabolic acidosis and insulin deficiency, we see hyperkalemia due to reduced excretion secondary to acute renal failure, chronic renal failure, or due to reduced aldosterone action or levels of reduced aldosterone level or its action, reduced action on its receptors. We see hyperkalemia in Addison's disease, ACARB drug intake, and ketoconazole drug intake. And pathophysiology of clinical manifestation, the resting membrane potential is usually between minus 70 millivolts to minus 90 millivolts. Due to hyperkalemia, there will be reduced concentration gradient of potassium, which causes RMP, that's resting membrane potential, to be less negative, which causes the increased excitability of the cell. The sustained depolarization will inactivate voltage gated sodium channel, which leads to muscle weakness and paralysis. The impaired functioning of the potassium channel, which causes impaired repolarization, causing tall, slender T waves. Coming to clinical manifestations of hyperkalemia, we see muscle weakness, flaccid paralysis, paralytic ileus, and cardiac manifestations like hypotension, bradycardia, ventricular fibrillation, cardiac arrest. In investigations, initially we see tall peak T waves followed by reduced intracardiac conduction causing loss of P wave wide and QRS complex, and at last stage we see sine wave pattern when the potassium level is more than 8 milliequivalent per liter. At this stage, the patient can develop ventricular fibrillation and cardiac arrest. To prevent cardiac arrhythmia, we give calcium gluconate 10 ml of it in 10% solution, IV given for 2 to 3 minutes. To increase potassium excretion, we can give diuretics, sodium polystyrate sulfonate, and we can perform hemodialysis in the renal failure patients. To increase the shift of potassium from the blood into the cell, we can use salbutamol, sodium bicarbonate, or insulin with dextrose infusion. This is all about hyperkalemia. Thank you for listening.